Migraines are extremely common. On a yearly basis, 12% of people will have at least one migraine, and obviously many of those patients will have more than one migraine per year. And it's by far the most common reason a patient ends up seeing a neurologist is for a migraine. But it's also a very common reason the patients are in the emergency room, and patients see their primary care doctor as well. And as you can see from the numbers up there, it's considerably more common in women than it is in men. And maybe some of you have had migraines before, and that's why you're here. But it is as well a very disabling condition. Not in the sense that, you never work again like disabling, but when someone's having a migraine, they're obviously very unable to participate in sometimes their job and just in their normal day-to-day activities. And for patients who have a lot of migraines on a monthly or weekly basis, it leads to a lot of impairment. And by some measures, it's the second leading cause of disability among neurological diseases, and that's second only to stroke. I would like to, before kind of jumping into the therapy of migraine, just talk a little bit about what the features are of a migraine. And it's broadly divided into these four areas that I have listed. First, I'd like to talk about the headache of it. And but if I was hired as a PR representative for migraine, my spiel would be that migraine is more than just a headache. And that's why I created my little advertisement. This is what I'd show to migraine to try and get me to allow it to be its PR representative. And I'm very fond of this squishy brain that I found, this image online. Squishy brains, these little things that you could kind of hold and use as a stress reliever. Back in the day when drug reps roamed the hospitals more prominently than they do nowadays, squishy brains with all sorts of drug names were very common gifts to physicians. I wish I'd saved all of those that I'd gotten back in the day, but I alas did not. So I kind of got sidetracked while researching this talk and started looking for other squishy brain images. And I actually found this one. And I thought it did a beautiful job explaining what the pain of a migraine is. And I love the hammer because by far the most common description I get from my patients is that the headache is pounding. Sometimes they say pulsing. Now often that pain, but not always, is on one side of the head or the other, but sometimes it's diffuse. And of course I also hear about squeezing pressure, like this poor squishy brain is suffering right now. This brain will never be the same. These are all common ways to describe the pain of a migraine. Now, the pain of a migraine is it's best characterized by what is associated with that migraine. And by far the most common associated symptom with a migraine is what we call photophobia. And photophobia is that sense that light is increasing the pain of the headache. And another description of photophobia would be being willing to wear any sunglasses that look like these. Other than photophobia, I will hear almost as often about phonophobia, which is a sense that the noises are just too loud. And it leads between the photophobia and the phonophobia to common feeling with a migraine that the quietest, darkest place you can go is the best to be. And that's where many patients with migraines will retreat during a severe headache. In addition to these two symptoms, another common symptom, especially with severe headaches, is nausea. And so that sometimes leads to emesis, but nausea is a little bit more common without emesis with migraine. And about 20% of patients will have migraines with occasional auras. Not all of their migraines will have auras, but many of them do. And the most common aura is a visual aura. And hard to kind of make a picture, but these, I guess, are some artist impressions. And the kaleidoscope is included because it's one of the more common descriptions I hear, is that it looks like feel like I'm looking through a kaleidoscope. We also get these visual obscurations. The world that you're looking at is missing parts of it, and these parts that are missing is moving. Sometimes it's through both sides, sometimes it's just on one side that it occurs. Less common auras include dizziness. Dizziness, it's hard to describe as a lightheadedness or a frank spinning, but a dizziness nonetheless. Rarely there are auras that have weakness, or even some patients have auras where they can't speak or even understand language. More common is a sense of, certainly more common are the visual auras and the dizziness than the more severe aura symptoms. Over the last 5-10 years, we've become more aware that there's more to the headache than just the aura and the headache itself. And so many patients will tell me that in the days before their migraine, that they got very poor sleep. And we used to interpret that then as the lack of sleep is what provoked the migraine. Sleep better then, just get more sleep, you'll be fine. But what we now seem to know is that it's the migraine itself that hasn't declared itself with the pain or the aura that's leading to the poor sleep itself. You're sleeping poorly because of the migraine that's going to happen 2 days later, not then having a migraine because you slept poorly. These symptoms of a prodrome besides the sleep include fatigue and some difficulty, some sort of mental fogginess, and can last several days before a headache begins. And of course, if there's a prodrome, there has to be a postdrome. And that postdrome is after you've experienced some relief from your headache. You don't feel gung-ho and awesome and ready to take over the world, but instead you feel still some of the same symptoms, but often those symptoms are more common with the postdrome relative to the prodrome is some gastrointestinal issues, a lack of appetite more than anything. These postdromes then also last for several days. Now, some of my patients will have migraines 4 or 5 days a week, and they're experiencing these severe headaches and not feeling well otherwise outside of their headaches. And you could argue then that they're just going from one postdrome into the next postdrome into the headache and, repeat over and over again. And this is why patients with migraines tend to feel unwell even when they're not having headaches. So now we get to therapy. And when I talk with patients about therapy of migraines, I split the therapy into 2 different types. And I first want to talk about abortive therapy, which I liken to the ambulance, which is you have a headache, you want to feel better, and so you take one of the abortive therapies. The majority of patients with migraines don't ever see a neurologist. Many of them don't ever go to a physician because their treatment in over-the-counter medications can be very effective for a lot of patients with migraine. And the over-the-counter medications include aspirin. Before ibuprofen was invented years ago, aspirin was the go-to medicine for migraines, and patients would take so much aspirin they would have ulcers from the aspirins, as well as some other toxicities that we no longer see nowadays because of ibuprofen. Nevertheless, some of my patients still use aspirin. More common are the non-steroidal anti-inflammatories like ibuprofen or naproxen. And to be effective, they're used at much higher doses than what's recommended on the over-the-counter labels. And of course, Excedrin is extremely popular over-the-counter medication for migraines. We have prescription medications, and the most commonly used prescription medications are, their generic names all end in triptan, as you can see, and so they're called the triptans. And these fortunately are all available generically nowadays, but these medications sometimes are effective alone, but usually when I offer these to my patients, I'm still recommending that they use them in combination with over-the-counter medications, usually something like a high dose of naproxen or high dose of ibuprofen. Now, as for abortive therapy, there's a couple things I wanted to emphasize. When you have a migraine, the earlier you take an abortive therapy, the more likely it is to be effective. And so there's a window, a therapeutic window in migraine, and that window is closing the longer you have the symptoms. And so the longer you wait to take the medication, the less likely it is that something is going to work. And so in that point of a migraine where you get to the point where it hurts to touch your head, part of the migraine, studies have shown that by the time you get to that point, ain't nothing gonna work. And so that's why you need to take these medications earlier rather than later. It's worth emphasizing that many of the prescription medications like triptans come in different formulations. And so when someone has nausea with a headache, the equivalent of nausea in the stomach is actually swelling of the stomach walls. And so with headaches with nausea, it's harder to get oral medications into your system. And with the triptans, we have nasal formulations, so something that you stuff up your nose. The first one to have a nasal formulation was sumatriptan, but that sumatriptan nasal formulation would leave a taste in people's sinus that would last weeks. And so it wasn't very well tolerated. Zolmitriptan also has a nasal formulation that seems to be less likely to cause that weird taste in your sinus, of course, which is a weird taste in your mouth as well. There's a formulation of sumatriptan that comes that you can have injected, and with the injection formulations and with the nasal formulations, we get the medicine into our system quicker, and we're more likely to get effective abortive relief. There are several of the triptans that have a sublingual formulation. So just like sublingual nitro that people would take with a heart attack, you stick the triptan underneath your tongue and it's absorbed that way. There's less clear evidence that it gets to your system more quickly than the oral formulations, but still some patients benefit more from the sublingual stuff than they do from the oral stuff. Now, of course, the problem, at least with the nasal formulations and the shots of triptans, are that they are much more expensive than the pills. And so patients who might benefit from having the injections several times a week are still going to have an insurance company that's going to provide 2 of them per month. And that's not something I've very successfully gotten around your insurance companies with in terms of the authorizations that we do to try to increase the amounts that are provided. Rebound headache. So when patients have very frequent headaches and they're taking over-the-counter or prescription medications to get rid of the headache on an almost daily basis, are going to have a headache on an almost daily basis that's probably being worsened by the medication they're taking to get rid of the headache. So it's a crappy situation, to say the very least. And among the over-the-counter medications, the one that is the most likely most commonly associated with rebound headache is the Excedrin formulations. And that's because the caffeine and the acetaminophen are very short-acting medicines. They're there and they help you feel better for a while, but they leave your system before the headache's been totally thwarted and the headache comes back. You take some more, rinse, wash, repeat kind of cycle. And the triptans as well can cause rebound headache. The reason triptans don't cause rebound headache very frequently in this country is because triptans, even though they're generic, are still quite expensive, and your insurance company only gives you 9 per month. That's probably, and don't tell any insurance company I said this, but that's probably a good thing. And that's because with that restriction, we're decreasing the amount of rebound headaches that we're getting from triptans. And I wish Excedrin, which otherwise can be a great medication, had that warning on its label as well, because it's one of the more common situations I get involved is when someone has a daily headache that is rebound associated. With prescription drug crisis that we have today, I'm seeing less and less of opiates like oxycodone and hydrocodone prescribed for migraines. I still do, and I occasionally run into patients who are taking hydrocodone formulations 3 or 4 times a day for their migraines on a daily basis every single day. This causes rebound headache. And of course, opiates have an addiction issue. There are medications that used to be used more frequently before the triptans came out that have barbiturates in it. And the name brand of these was Fioricet, which, although effective in some people, has a habituating effect in that more and more is necessary over time to get the same benefit, and it is a barbiturate. When I have patients who are using Fioricet on a daily basis, I have to put them on stronger barbiturates just to taper them off of these medications. So pregnancy really is the worst. And I speak from no experience whatsoever. But in the setting of pregnancy, none of these medications can really be used. We can use Tylenol, which is not everyone's go-to medication for migraine because of the rebound effect. We can't use the triptans because they haven't been studied in pregnancy despite being around for decades. And so when I have a patient who has frequent migraines, which occasionally get worse during pregnancy, I'm reminding them that there's an end date to their pregnancy, thank goodness. But I'm using primarily caffeine and acetaminophen. And then they tend to be worse in the first trimester, and like everything else is, and so they tend to improve through the pregnancy anyway. The other class of medications that are used to treat one more thing on abortive medications is that There are old medications that we use for nausea, like Compazine and Reglan, and these medications are very helpful for some patients with migraine. And so someone has a migraine, even if I have abortive therapy that's really effective for them, I'm hoping the abortive therapy works 3 out of 4 times, and they're occasionally going to still have severe headaches. I don't want to have to make them go to the emergency room every time. The emergency room is a horrible place to be with a migraine. It's bright and it's loud, and everybody thinks you're looking for narcotics from them. And so they're ready to sign out in terms of their daily responsibilities and just need something to help them get a rest while their headache improves of its own accord. And medications like the old antiemetic medications can help them rest and help their headache get better. And these are called rescue medications. You're not going to work anymore, but here's something to help you feel better until you can get back to your normal activities. Now the other type of medications. And so if abortive therapies are the ambulance, preventative medications are the mortgage. You have to take them on a daily basis. You have to pay it forward. And the reward of a medication that is effective then is that you have less headaches down the road. And with many of these preventative therapies then, the studies, when they look to see if they're effective, they're looking at what percentage of people have a certain percentage of reduction in days with headache per month. And so some of these medications, the stronger medications, the trials show that they're having 50% of people are having 50% less headaches. And that's what's considered a good response to these medications. And of course, there are people who have less of a response but still a benefit and stay on the medication. And we have situations where there's a more dramatic benefit and the migraines are completely gone. The older medications, and so I call these the old school medications in honor of Will Ferrell and Old School. These are all medications that are used for other things, and kind of accidentally, someone with high blood pressure noticed that their migraines were less frequent on this medication. And studies showed eventually that these medications were beneficial. And the first group of medications that came into use this way were all blood pressure medicines, antihypertensives. And among the more commonly used antihypertensives are the medications that are called beta blockers. And the one that neurologists tend to use most is a medication called propranolol. Now, these medications lower your blood pressure a little bit, but they lower your pulse as well. And of course, then the number one side effect of having your blood pressure lowered is that you're going to get lightheaded sometimes. Ironically, when I have a patient who comes in and has high blood pressure and migraines, I don't use the beta blockers very frequently. And that's because we know from studies of treatment of people who just have hypertension that treating them with beta blockers alone doesn't affect their ultimate outcomes in terms of reducing their risk of heart disease and stroke. And so you come in with high blood pressure, I treat it with my beta blocker, I'm not affording you the additional protection of having your blood pressure treated. And so some of the other blood pressure medications have been more recently studied to try and see if they would reduce migraines, particularly the ones that also offer, vascular benefits. And the most useful of these are medications that are called ACE inhibitors like lisinopril, or angiotensin receptor blockers like candesartan. And so these are the medications that I'm more recently reaching for when I have someone who has high blood pressure and migraines. Antidepressants are useful for migraines, but not all antidepressants, not your medicines like fluoxetine or sertraline, but very certain classes. And One of these medications is a very old medication called amitriptyline, and it's among a class of medications that are called tricyclics. And nobody uses these for depression anymore. Hardly anybody uses these for depression anymore because they have side effects. And this is why everyone was so excited when fluoxetine came out, because amitriptyline, although it could help depression, also caused instability and sedation. So it helped people sleep at least, but it also caused weight gain. And since weight gain is not good for migraines in general, giving patients a medication that helps them gain weight doesn't seem to make so much sense to me. So sometimes I use amitriptyline, but usually it's in a patient who has insomnia, and I pull it out when I find patients who are very thin and whom I wouldn't mind them gaining a few pounds. So when I want to plump them up, I guess. Newer antidepressants of the class that are called serotonin norepinephrine reuptake inhibitors, or SNRIs. These medications are venlafaxine, desvenlafaxine, and a medication called duloxetine. Now, duloxetine was marketed as Cymbalta heavily for diabetic nerve pain and for fibromyalgia. There are studies showing that these medications have a modest benefit in reducing migraines. Finally, there are seizure medications that are useful for reducing migraines. And the oldest one is a medication called valproate. And I hardly ever use this medication. It causes so many different weird things, including liver damage and thyroid disease and tremor. It causes polycystic ovarian disease. If you get pregnant on this medication, there's a very high rate of birth defects as well. And so I guess I might use it in a young, healthy male, but that's about it. And by far the more commonly used medication nowadays is topiramate. And almost everyone who has frequent migraines by the time they see me has already had a trial of topiramate. It's medication, though, that compared to the antihypertensives and the antidepressants, you start adding risk to side effects. And so it's one thing if you feel crappy and you have a side effect. It's another thing if a medication causes damage to some organ that we like kidneys or eyes, and doesn't get better once we stop the medication. So topiramate's most well-known side effect is that it increases the risk of kidney stones. I'm told kidney stones hurt. Many of the kidney stones I've caused over the years have led patients to dislike me for long stretches of time. And it also causes glaucoma. Topiramate causes cognitive problems in exactly 18% of patients. They have a hard time finding words, and some people get more anxious on topiramate, and even more than the kidney stones and the glaucoma and the word finding stuff, the idea of making someone more anxious probably worries me the most. But I tell patients ahead of time. And when I am anxious and I know why I'm anxious, I'm not crazy. When I'm anxious and I don't know why, that's when I'm crazy. And so warning people ahead of time that a medication can make them more anxious, they stop it, they're going to feel better. It makes a considerably better experience overall for everyone. Now, if I'm going to have a group of old school medications, I needed to come up with a name for the newer medications. And so I wanted to use newfangled, and then I thought of hip, and this one's a new one that young people say, bleeding edge, but groovy, oh, another one, yeah. But I decided to stick with newfangled. The first one I want to talk about is at the bottom of the list, and that's botulinum toxin. And this is something that was discovered accidentally, and so people were getting botulinum toxin to get rid of their wrinkles. And Also, people were getting this therapy for eye problems, and so there's some neurologic diseases that lead to eye closure and involuntary eye closure. They also happen to have migraines with their wrinkles or eye closure problems, and they told their doctor, "Wow, my headaches are better. What are you doing?" And this information kind of slowly got to the company who makes botulinum toxin, and they of course were interested in making more money, and so they did big studies and showed that it's a fairly effective treatment for migraines. And for the longest time nobody really knew why. In contrast to all of the other medications that I've mentioned, botulinum toxin doesn't even enter the brain, but it reduces migraines. And so it was the first time that we had a medication that didn't enter the brain that reduced migraines. Turns out that there's some thinking that nowadays that the botulinum toxin is working very much like this newer class of medications, the CGRP antagonist. And so with botulinum toxin, you come in and see a doctor. All of the doctors at Midcoast do this. You get 31 shots. It takes us about 10 or 15 minutes to give you those shots. And from the reaction I get when I put the needle in someone's head, not into their brain of course, but just under their skin, it seems to hurt. And but the needles are very thin and it goes relatively quickly, and the shots that are around the forehead hurt the most, but the ones around the side and the back of the head tend to hurt a little bit less. We have to do these injections every 3 months, and so it's for some of my patients who get these injections, I don't think would come back to see me for the next set of injections if it wasn't for the botulinum toxin wearing off and them getting migraines every day again that lead them to come back to see me. And botulinum toxin, like topiramate, in the study showed that about 50% of people experience a 50% reduction. Now, how that translates to the real world is that we see a higher benefit. And that's because in the studies they have to compare things to placebos, and I don't have to, so I get the placebo benefit as well. And so we tend to feel like it's more like 60% of patients who experience a 60% reduction with this medicine. And again, it's similar to topiramate, but arguably has a lot less risk. Now with these injections, all these medicine stays local and all the side effects are local. And so the most common thing people complain to me about is that I make their eyebrows droopy. Now, I'm not making their eyelids droopy, I'm making the eyebrows droopy. And so everyone has this excited look that they do when something exciting happens, where you go like that. Once I give you botulinum toxin, you can't do that anymore. You look really silly. And in fact, sometimes patients outside of their eyebrows will go up and their middle won't, and they'll look like a cartoon character when they do that. The injections to the side of the head sometimes affect hearing, and that's because our ears have muscles in them, and so they'll make things sound louder or sound softer. The injections around the back of the head really seem to be far more benign. Occasionally someone will feel like their head is falling forward a little bit, but it's really, in terms of side effects, it's all about the forehead usually that this causes. Now, the reason everyone has to try old school medications before the newfangled medications is because of the expense. And so these new medicines are ranging somewhere between $5,000 and $10,000 a year. And that's actually a reasonable cost, honestly. And it's reasonable because, again, we're talking about a disease, or a syndrome at least, that is the second most disabling neurologic disease. If you reduce someone's headaches by 50 or 60%, and they can work more and their quality of life improves. If you're an economist, you then measure their benefit and you assign an arbitrary number to the worth of their 1 year. The value of $5,000 to $10,000 a year is actually a reasonable cost. Unfortunately for botulinum toxin, nobody's aware of it ever becoming generic, ever. And so that's because of stuff that I don't understand with how it's regulated through the FDA. The newer medications came out earlier last year, and they're monoclonal antibodies. And so what that means is we have antibodies in our immune system. They're very sensitive structures that can determine whether something inside you is you or something that is invading you. And so when you set a monoclonal antibody on something, it's going to hit what you send it to. And many of our newest medications that have come out over the last 10 years for treatment of all diseases have been these monoclonal antibodies. The most common one is a drug, who I can't remember the generic name for it, so I'm sorry. It's Humira. And that's the most prescribed drug by cost in America for many years now. These antibodies, these monoclonal antibodies then came out early last spring. There were 3 of them, and their generic names are there. The name brands of these medications were Aimovig, Ajovy, and Emgality. And it makes me feel like they're finally running out of name brands for drugs. Aimovig sounds like a character from Game of Thrones. Ajovy sounds like anchovies. And Emgality sounds like something you screamed during the French Revolution. Emgalite! Emgalite! Hundreds of thousands of prescriptions of these medications have been written already. And so we're beyond the point where we have to worry that there's something rare that they're doing that we don't know about. One of them causes constipation, but not very much and not very badly. The other ones have a hard time showing that they have any side effects other than reactions at where you put the needle. Some people have some muscle weakness with them rarely. And so we're talking about medicines that with the monoclonal antibodies, any side effects based on how specifically this medicine attacks something is not a side effect, it's the effect. And so these medicines though are so new, and so there's still this lingering worry about some chronic associated something that they might do over time that we'll become aware of. And several years ago, there was a class of diabetic medications that really did a good job to lower blood sugars. And it took several years before we realized that there was a slight uptick in coronary artery disease with these medications, and many of them were pulled from the market. This protein that they're attacking in the body is fairly ubiquitous. It's all over our body. So there's a little worry that we're going to have, that there's something chronically that they may do to someone that we're not going to become aware of with time. So in my practice, I've tended to reserve these medications until after someone's tried almost everything else. And obviously I'm a little bit more conservative in that regard compared to most doctors because, like I said, hundreds of thousands of prescriptions have been written for these medications. I've probably prescribed somewhere between 20 or 30 patients on these drugs in the last year and a half since they came out, and that's fairly similar to most of my partners. This is an injection you give yourself once a month. You find some soft, poochy place on your body with lots of subcutaneous tissue, which is also known as fat. You put it in there, and you do that once a month. The injection itself is not something you draw up like heroin to put in your arm. Instead, it's something with a trigger on it where you just push it against the skin, you press the button, and the needle goes in and out so quickly you don't know what happened. So a lot of my patients come and ask me about supplements or herbal medications. And I guess the point of this picture here is to show that I'm a little bit skeptical in general of herbal medications and supplements. There was one of these herbal medications that used to be used fairly widely in the US was based upon research from Germany. And it was used widely in the US. And it took us a year or two to realize that whatever the herb was in Germany wasn't the same herb in the US. Unfortunately, there were several cases of liver problems from people who'd been on those herbal medications. And therefore, my interest in recommending herbal medications to my patients rapidly declined. That said, among these medications on this list, the ones that I think the safest are, of course, riboflavin, which is just a B vitamin. This recommendation to take riboflavin has been around forever. It's based on a study of about 40 people that's never been replicated otherwise, but no one has any skin in the game in terms of making a lot of money off riboflavin, so that's all there ever is going to be. Magnesium is an interesting supplement for headaches, and I have patients who very rapidly improve with magnesium for their migraines. They tend also to be constipated. They're probably magnesium deficient, but you can't test for true magnesium deficiency with a blood test so much. Magnesium largely resides in the cells, and it almost requires a biopsy to figure out if someone's magnesium deficient. Maybe the reason you have to be constipated to take magnesium to improve your migraines is because magnesium makes you poop. And this is why we sell milk of mag, in every pharmacy. It is a supplement that will keep the bowels moving, and so being constipated makes it a little bit easier to handle. Coenzyme Q10 is widely available, and among all of these seems to have the most evidence showing that it's beneficial for people with migraines.